didn't want to bore you with a lot of information, but this is some of the data we look at. When I look up here, this I like. Patient had no shocks, but he had one charge where he may have got a shock. So I'm going to look at that. This patient had 75 days, more than 6 hours of AFib a day, and the activity is less than 1 hour per day for 10 weeks. Put these two together, and it kind of sounds like, well, that AFib's not doing very well for him. Here's a battery status. It's beginning of life. BOL, beginning of life. ERI, elective replacement indicator. It tells me here's my voltage. It tells me when that battery voltage was measured. Here's another one that tells me have there been any detections. I like zeros. Here's a gas gauge that shows me longevity, loss of battery voltage. This one tells me what the heart rate's been. If this is an ICD patient and I see they have heart rates that are going up into the 160, and they have a heart rate cutoff of 150 for therapy, I'm going to be bringing them in and see what's going on. Here's another one, events since last follow-up. It had a VT event with a rate of 159, and here's a VT event with a rate of 154. And then here it says battery okay, approximate time to explant 3 years from March 18th. And here's my battery. So this is the data we get. This is what I call the nuts and bolts data. It tells us how good the function of the device is. Now, we have a device database where all of our patients reside. And we use the bottom, I call it sticky note part. We use that to comment so that we know when a patient calls in, if we've talked to a patient, what's been going on. So here, we left a message and rescheduled a courtesy call. After implant, we called the patient to see how they're doing. Okay, patient called. States he doesn't want to be called for the courtesy call. It's annoying him. Okay, now we're into January. He missed his care link, which is a remote follow-up. Quote, we'll open the box in the next couple of days. Please don't be this patient. We're trying to take care of you the best way we can. And if we can't get the data and you're not listening to us, it's very hard for us to take care of you. Some questions, and these are always questions that come up early on into the ICD therapy. How do I know that you received it? It's a leap of faith. The first time you send a transmission, the question is, gee, how do they know they got it? Well, each practice is different, but they could be sending you a letter, they could be calling you, or doing a no news is good news, but they need to let you know what manner they're going to respond to you. In our practices, we're going to call you if there's a problem. Feel free to call us at any time, but we're not going to call you just to say everything's fine. So you could give them a call. We take a lot of patient phone calls. We call them just patient's reassurance. And we'd rather have you call us and we can answer your questions that way than, rely on, gee, don't give me CPR. Well, if you're telling them don't give me CPR and you're the one supposed to be getting CPR, that would be something else. But those are questions that we need to answer because those are, I call them old wives' tales or urban legends, and they just don't seem to die out. It's like the microwave and the cellular phones involving the ICDs and the pacemakers. What if I think I've had a shock? Now, I'm not even going to ask how many people have had shocks because that's a private thing, but how many, a lot of times somebody who's had a shock then thinks they may have had a shock the next time. Your mind will play tricks with you. Each practice will handle this differently. What we've done is first, how do you feel? If okay but frightened, give us a call. We will ask you to send us a transmission in case we didn't receive a transmission so we can look at it and make sure everything's okay. But if you don't feel well, don't call us, call the friendly 911 people. Because we want you to get taken care of. What if I'm having chest pain? Don't call us. Your defibrillator is for rhythms. Your pacemaker is for rhythms. Chest pain can tell you there's something else wrong. So I put this in here because this is a common question, and I had a phone call. A patient called about this, and because I had called them, they had a lot of VT over a few days, and I knew this patient wasn't doing well. And so so I called them, and they said, well, we're worried that he's had a heart attack. And I said, well, your device won't tell me you've had a heart attack, because a heart attack is something different. It will tell you if you've had arrhythmias or fast heart rates. It won't tell us anything about blockages. It won't be able to tell us anything about that. It tells us if you've had atrial fibrillation, VT, a shock from VF, any of that, but it won't tell us if there's any blockage. So again, an arrhythmia episode is an episode that causes your heart rate to speed up to an extremely fast heart rate. And your device will treat the fast heartbeats, but can't treat a blockage in your coronaries. Those can only be treated by a cath, maybe stents, or open heart surgery. So who pays for the remote transmission? Are all of you in Ohio, did the Kentucky people show up? They did show up. I don't know about Kentucky, but I know in Ohio, Medicare and your third-party payers will pay for remote transmission. If you've had a problem, check with your practice and the billing people, and they can help you get it straightened out. But is there a copay? And that, again, I can't answer for any of you. It depends on what your insurance structure is. And if there's a copay, you'll still have to do a copay. But the remote coverage,
My insurance doesn't even know anything about this. I mean, they don't get anything. Obviously, I'm not paying anything.
well, they're sending a bill. Your provider's sending the bill.
You mean my doctor?
Yeah.
Oh,
Okay. So your insurance company knows about it, because if they didn't pay it, you'd be getting a bill.
okay. Because I'm not even paying for part of the bill.
Yeah, that's fine.
Okay.
Don't.
I've got enough issues.
You got enough issues. But again, it varies with your insurance carrier. And since there's what, 50 people in here, there's probably 50 different insurance carriers. So again, you have to check with your insurance carrier, and your practice manager, whoever does their billing, can help you out too. So comments. Remote monitoring is a way for us to take better care of you by utilizing your device and monitor combination gives early warnings of issues that may come up. We want to take the best care of you that we can. That's why we do this. It helps us so much to get data ahead of time so we can be proactive, hopefully prevent anything untoward happening to you. But you need to be part of this also by following suggestions of your follow-up center. You need to be educated about your transmitter and when to use it and who's looking at it and that type of thing. Keep the transmitter plugged in if it's wireless. I can't tell you the number of patients. We send out letters 3 weeks ahead of time because a lot of patients don't keep their transmitters plugged in. And there's many reasons. Dog ate the cord, the lights bother me. I mean, we've heard them all. But we'd like you to keep that transmitter plugged in if it's wireless, because that's how we get our early warning systems. It won't send us any information if it's not plugged in, if it's in the box in the cupboard. If you need to send transmissions, send them in a timely fashion. If you're a patient that has to do the wand, and we tell you we need it on April 1st, try to do it on April 1st, so that we know that you're following what we've asked you to do.